Good evening, everyone, and welcome to tonight's webcast, Smarter Fitting, Better Outcomes, Designing Ortho-K Lenses with the OCULUS Pentacam. Before we get started, a quick housekeeping item. We encourage everyone in the audience tonight to submit any questions they may have. You can submit these in real time, and you can use the chat box on your screen to submit those. We'll get to as many questions as we can, time permitting, here at the end of the session. Now, tonight we're very excited to have Dr. Jason Jedlicka with us. Dr. Jedlicka is a clinical professor at Indiana University School of Optometry and the chief of the Cornea and Contact Lens Service. He is a past president of the Scleral Lens Education Society, a diplomate in the Cornea and Contact Lens section of the American Academy of Optometry, and a fellow and past board member of the Contact Lens Society of America. He has special interests in studying ocular surface shape and contact lens design, and is a partner of Lens Design Solutions, a contact lens design development team. Now, without any further ado, Dr. Jedlicka, the floor is yours.
Thank you very much. And again, welcome everyone to our webcast this evening. We'll get to talk about Ortho-K lenses and the Pentacam in particular. And so I'm excited to bring this to you. So again, I presume you all know what a Pentacam is all about. Pentacam is an anterior segment tomography instrument. It uses Scheimpflug imaging to take multiple cross-sectional views through the anterior segment and reconstruct a three-dimensional model. And from that, we can then, of course, understand the shape of the cornea and even somewhat the sclera, depending upon the test we run with our instrument. So again, the Pentacam is it's a device that has so many applications and so much power to it. And so we'll talk a little bit about why Pentacam for Ortho-K. And again, just to reiterate, the Pentacam, if you look at what it does, again, we're taking cross-sectional images through the anterior segment, and the images we're getting are greater than the corneal diameter. So if you look at the little picture on the right there, you see the little red lines, and that's the area we're imaging, like 14 millimeters. So it's important to note that the Pentacam is going to give us full corneal data. It's going to give us cornea and a little beyond, which is really important when it comes to designing contact lenses that we want to be nearly full corneal. And as we talked tonight about Ortho-K lenses, that is part of our plan, is to make our lenses nearly full corneal. And if we want our lenses to be accurately fit, if we want first fit success, if we want to be able to fit complex corneas, again, effectively and efficiently, we need full corneal data. We need it to be accurate. And Pentacam gives that to us. Just, going back, I've been doing Ortho-K for maybe 20 years. And I recall that in the early days, we used corneal topography, and corneal topography is great. I have a keratograph in my office that we use all the time too. And for many years, I used my keratograph, my Placido disc topographer, to do my Ortho-K work. And again, it's very effective. It has great application. I still use my keratograph every day with my Ortho-K patients. But maybe 5, 6 years ago, I was talking with Bill Tulo from Oculus, and Bill encouraged me to try using the Pentacam as well. And so we started doing Pentacam and keratograph on every patient we did Ortho-K on, both pre-treatment and then afterwards as well. We just ran them both, just kind of see how it went. And I would say that as we transition to using our Pentacam for our baseline imaging that we used for lens design, that our first fit success was significantly improved. And so again, we're talking tonight about the Pentacam for Ortho-K lens design. And I'm not going to say that there isn't application for Placido disc topography in Ortho-K. There absolutely is. But when it comes to lens design, I think you just can't beat the data that you get from a Pentacam, and that's what we'll cover tonight. So the topics that we'll go through with the Pentacam for Ortho-K are these four. We're going to talk about how Pentacam gives you a unique angle at detecting at-risk patients prior to fitting. And as you know, when you undertake to do Ortho-K, if all goes well, you're going to reshape that cornea for a long time. And you're not going to have an opportunity to go back and compare necessarily to pre-Ortho-K maps, because they won't compare once you've reshaped the cornea. So looking for things like like keratoconus or things like that developing in our teenage Ortho-K patients is critical, and we want to try to detect those patients who may be at greater risk prior to fitting, because we may decide that Ortho-K isn't the best thing for them because it really doesn't allow us to monitor the shape of the cornea that carefully long term. So we may choose some other type of myopia management procedural instead of Ortho-K. So again, just we'll talk about that. Pentacam gives that to you where regular corneal topography doesn't. We'll also talk about the value of full corneal data for full corneal lenses. If we want to design a lens that is 11 and a half millimeters or thereabouts, we need to get data out to 11 and a half millimeters. Otherwise, our lens will not necessarily be accurate that last millimeter or two in the periphery. We'll talk about using data to design lenses. So the Pentacam can give you data that you can then use to design lenses. And so you may prefer to work in a situation where you make measurements of your patient and you call your lab, you call your manufacturer, and you give them data. You may give them Ks and Rx historically. Maybe that's what we did. But we know that going forward, we're able to get better outcomes by giving more data to our lab. And so we'll talk about how Pentacam can give you important data points that allow you to have lenses designed through your manufacturer empirically with greater accuracy. And then we'll also walk through how Pentacam integrates with different software programs that you can use the other programs to design lenses as well. So again, detecting at-risk patients. What do we get when we do a Pentacam? We're getting pachymetric data, corneal thickness, which again is really critical. We're also getting posterior corneal shape, which is the most critical thing really when it comes to detecting ectasia or other corneal disease. And so those patients that may have borderline findings for pachymetry, for corneal shape, for posterior corneal shape particularly, you're going to detect those patients with a Pentacam, and you're going to be able to screen them and make better decisions for those patients in their long-term best interest. And we talk about that all the time. I will get text messages from colleagues who mention they saw a patient today and they show the Pentacam, like, what do you think about fitting this patient? It's borderline. And it's like, yeah, you would never have picked that up if you didn't have a Pentacam to look at that posterior cornea and that pachymetric profile of how the cornea progresses from thinnest to thickest areas. So it's really important, as we make measurements on our patients and we see suspicious looking eyes. See, let's look at this patient on the left, for example. You might look at that and say, this patient's got K readings of 45.1 by 45.5. That's a little steepish. But corneal thickness, if you look down below 447, that's pretty thin. And then if you look at the elevation map on the front, on the right eye compared to the left, we don't see evidence of any type of corneal ectasia. And what I mean is that the back elevation is not greater than the front elevation. If we look at the left eye, we see a similar thing. So this patient has really thin corneas, and are they suspicious for keratoconus still just because of that? Sure, that is a possibility. But if you look at their front and back elevation maps, there's no evidence at this stage that this is a corneal ectatic disease. This is just a plain old thin cornea. And so again, that's something that Pentacam can give you. It is something that can be monitored. And it's critical, again, that we have posterior corneal data, not just anterior corneal data, to be able to monitor this patient's risk. So again, this is a situation where you may be uneasy about proceeding, but I think it would be safe to go ahead and fit this patient Ortho-K lenses because, again, their back to front elevation is normal in shape. Here's another situation where we have a patient who's a little bit less steep. If we look at the K readings on the left side, we see 43.8 by 44.9, not quite as steep. K max of 45. Again, corneal thickness though, 454, a little bit suspicious. If we run this patient, we run the Bell and Ambrosio enhanced ectasia display, we do see a little bit of a yellow flag there on the center, our front elevation difference in the central area compared to the cornea as a whole is flagged as suspicious. And if we look at some of our indices down below, again, we're getting some yellow and red flags. So this patient is certainly more of an at-risk patient than the last one we just saw. The left eye looks similar. Again, that pachymetric progression we see at the bottom of the right below the maps where it says corneal thickness, spatial profile, percentage thickness increase. Those areas look outside of normal range. We see our red line moving in a shape which is different than a normal progression for a normal cornea. So again, this is a suspicious patient. And again, we may opt in this case to not fit them in Ortho-K, but to choose another modality for myopia management so that it's easier for us to check for signs of corneal disease in the future. Here again is another patient that we would look at their Ks and we'd see a bit of an oblique astigmatism. It might give us some concern. We'd see a thinner cornea, 509, a little bit on the thin side there. But again, as we look at the back of the cornea, not a great deal of suspicion for this patient. And if we look at their enhanced ectasia display on the right, everything looks okay. So again, Pentacam really invaluable at screening the health of the cornea of our individual patients. And again, some of these children, we're fitting Ortho-K on some pretty young children. We don't expect to see signs of keratoconus, but there are individuals at even age 7, 8, 9 that are showing early signs of keratoconus, and to be able to pick those up early on is really important. One other thing that you can do with the Pentacam that's really helpful, and this is just an example too, is once we've reshaped the cornea and the front of the cornea is altered through orthokeratology, we still can look just at the back shape of the cornea. And so what we see in the middle column here is a baseline map of a patient's back elevation. And if we move over to the picture on the left, we see now a map of that same eye a couple years later. And we can, again, look for signs of back elevation change, because really that's where we're going to see the signs of keratoconus showing up, right? We're going to see it on the back of the cornea more so even than we do on the front. So this allows us, even though we've altered the shape of the anterior cornea, we can look at the posterior cornea and do comparison measurements to look for signs of any type of ectatic disease. Okay, so other than screening our patients for any type of health concerns with their corneal health prior to fitting them in Ortho-K, when it will become harder to detect it later necessarily by what we've done, another benefit is that we're going to get full corneal data with our Pentacam, provided our patients have their eye open wide enough. And when we do a Pentacam, this is going to be kind of your initial general overview display that will pop up. This is going to show us our Scheimpflug image. And if you look at the upper left corner there where the star is, you're going to see a picture of the eye with a little blue line running through it. And that's going to give us an idea of how much of the cornea we're actually imaging. And so in this case, we're getting pretty much full cornea. We have a little bit of loss superior and superior nasal. And if we're really concerned, we may want to repeat the test and have the patient try to open a little bit wider. I do find that even though we don't necessarily always want to give our patients anesthetic for any reason, that sometimes when we want to get the eyes open real wide and get the most data, going ahead and giving a little drop of anesthetic can be beneficial to our patients to get a wider view. They'll tend to hold their eyes open wider and longer when their eye is less sensitive that way. Again, but this is a good place to look at our Scheimpflug images and see just how much of the cornea we've actually got in our imaging and whether we've got the full corneal data. Here's another picture we can see in the upper left. In this case, looks like the lids are definitely away from the cornea entirely. So we're getting more data and we're getting full corneal imaging. So again, we can feel confident if we're going to take this image and then design lenses using software, which is going to rely entirely on our topography, our tomography, to design that lens for shape. Again, the more data we have, the more accurate data we have, the more true data we have, the more our lens is going to be likely to be a good fit from the beginning. One other quality of the Pentacam that I think really makes a big difference. So again, as we transition from using our keratograph, for example, to do a lot of our lens design to Pentacam a few years back, getting full corneal data was really an important factor. We would get better peripheral curves, we'd get better edge clearances, we'd get better in the extreme periphery of our lenses using the Pentacam than we used to with just placido disc topography. And that again is because the Pentacam would give us truer data, accurate data, real data of the peripheral cornea, not extrapolated data, which we often get with an instrument that doesn't get the full cornea. So that was critical to success, was getting that full corneal data. The other thing that's really critical is that the Pentacam is not tear layer dependent. And that means, again, that we're going to get the true corneal shape that is not dependent upon whether the tear layer is optimal at the moment of our capture. And again, so the picture on the left here just shows a corneal topography, a placido disc topography, where we've obviously got tear breakup, and it's giving us some skewed data with that kind of blue-green line running through our map from 5 o'clock up to 7 o'clock. That same eye done on a Pentacam looks clean and pristine, and the curves look smooth. And so again, when it comes to lens design, having an instrument that is not tear layer dependent is really helpful to getting, again, better outcomes. You're getting better data, truer data, which leads to better fitting lenses. Now, again, there is some benefit at times to having that tear layer dependent instrument for follow-up. And so again, you may find that you may say, well, I like my topographer because it tells me when there is tear disruption and dry eye concerns, or when the surface of the cornea is affecting my visual outcomes, and that's great. But again, when it comes to lens design, it's really much preferable to have an instrument that's not tear layer dependent like the Pentacam, so that you don't have to depend again on a good tear layer to get right information. So again, those are some of the benefits of Pentacam when it comes to the pre-lens design process. It's giving us full corneal data. It's giving us true corneal data. It's giving us non-tear layer dependent data, and it's also screening out those patients that may not be good candidates for Ortho-K prior to fitting. Now, again, a lot of the lenses we design in our practice, we do a lot of software-based designs. We also do some data-driven designs. We do some lenses that we simply look at data from our map and call the manufacturer and give them key data points, and they will then use that to make lenses for us. So historically, again, most empirical fitting of Ortho-K lenses involved contacting the manufacturer and giving them essentially just their Ks and their RX. And with just Ks and RX, manufacturers would claim 80% first fit success. So that's great. However, more and more now, the labs are able to take more information from our maps and get even better outcomes, even better first fit success rate. And it's usually by adding corneal diameter, or HVID, horizontal visible iris diameter, and eccentricity values to the formula. When you add those additional components, you can now increase your first fit effectiveness from, let's say, 80% up to greater than 90%. And that is really helpful. So getting that data makes you more efficient and have greater lens success for those data-driven lenses as well. It also will help us to look for the need for toricity by looking at our elevation maps. And again, we have to remember that the Pentacam gives us true elevation data. All right, so the Pentacam is going to give us true elevation. Curvature from a Pentacam is a formula-driven process, but it's giving us true elevation, and that's really critical with Ortho-K. So different manufacturers want the data presented differently. So I just want to point this out, that if you go into your settings on a Pentacam, you're going to have the opportunity to express the data that you measure in different ways. So the shape factor presentation you see in the upper blue box on the right there, you can choose between numeric eccentricity, corneal shape factor, p-value, asphericity, for example. All these are options. And again, at whatever ring diameter you choose, again, 6, 7, 8, 9, 10, whatever you choose. This is something that if you're going to give your lab this data, you need to make sure that you preset the shape factor presentations and ring diameter to the values that they want for their lens. And so again, we work with different lenses, and sometimes they want the shape factor presented one way and sometimes another. So if you're going to try to provide this data to your lab, you want to check with them and say, how do you want me to give you the shape factor and at what ring diameter would be most helpful? And then you go into your miscellaneous settings on your Pentacam and you change these settings so that it's accurate and reflects what they are going to be asking for. So again, this is just an example of a map of a patient who might be considering Ortho-K. And the important things here, if we wanted to fit this patient in the lens, we might look at this map and say, well, it looks pretty reasonable to me. They have a little bit of astigmatism, but an acceptable level. I probably will need a toric lens because of that astigmatism. But in the yellow, we can see their K readings. So we would call the manufacturer and we would say, here's their RX. K readings 41.9 by 43.3. What else do we know? We would tell them that the corneal diameter is 12.2. So they might want to make a slightly larger lens. Again, my preference is usually going about 7/10 below HVID. So in this case, I would personally fit them in 11.5, but again, that would be up to the lab that you work with, but they'll want that information. You can also look at the elevation here, and you're going to see from the map, and you can look at the scale on the right and recognize that in the vertical meridian, we sit around minus 20 microns vertically, and we sit around plus 15 horizontally. So that's about a 35 micron difference, and that's absolutely enough difference for us to want to have a toric lens. So the lab, again, would want to know that data if they possibly could have it. We then could move to another screen, the refractive screen on here. And if you look in the center again, that's going to give us the numeric eccentricity values at 8 millimeters. And again, this is going to be set to whatever you put it at in the miscellaneous settings module that your lab wants that data. And so we can, again, give them information. We see a horizontal value of 0.56 and a vertical of 0.67. That information, again, we give to the lab and they would use that, again, to give us a better outcome with that first lens design. So data is absolutely a way that you can design your lenses, and beyond Ks and Rx, give them HVID and the eccentricity or whatever shape factor they want is going to be more helpful to them to get a better outcome. Now, we are in 2025, and there are so many good ways to design lenses using software nowadays that I do find myself going this way more and more, and it definitely helps with first lens success. And so we're going to talk a little bit now about how we can use our Pentacam data to do a better job of getting better lenses, smarter and better lenses through a more effective lens design using software. And there are several software programs that you can use to create lenses. This is not a complete list. I just mentioned the ones that I use in particular. We use the Wave software. We use iSpace, and now the new Arise lens is available. And these are just to name a few. I would really encourage you, if you're not doing anything with a software program, that you look into having this. I'm not saying you necessarily want to do a software-based lens for every single patient, but again, there are absolutely patients that will come along that challenge us because of a higher degree of astigmatism, let's say, or a larger or much smaller cornea. And so having a software program allows us to do a little bit more to customize that lens and provide our patients a better outcome. And another circumstance would be a patient with a bit of a quadrant specific cornea. They do exist. If you're interested again in any of these or others, I would say you want to contact the individual companies directly. This is not something that you necessarily contact Oculus for, but they will. There are ways to, again, to connect the software to the Pentacam software so that you can take your map and open up a new screen and it will populate the software with the map. Or there are also some that work in the cloud, and it will pull up your Pentacam into their cloud-based design software where you can then create the lens in that modality as well. Again, lens design software I find is not always necessary for the straightforward patient, the patient with no astigmatism, low prescription. A lot of times they're pretty straightforward and easy. But if you want to take on more challenging cases, absolutely using software makes it much easier for us. So I'm just going to walk through a couple of cases here, and these are just a patient. We'll talk about how we can use data and or different software programs to design lenses. This is case number one. We have a patient here who you can see the RX in the upper right corner, a low to moderate myope with a little bit of cylinder. You can look at their map in the upper left corner. You can look at the image of the Scheimpflug image showing us that we've got reasonably good coverage of the cornea, just to maybe again a sliver in the superior quadrant where we don't have data, but probably enough to be acceptable for a lens design. We can see the patient's data. We can look at their curvature map on the bottom right and see that again that they have that little bit of astigmatism we saw in their prescription. Then I would just take a look at their maps. You could look at their refractive data, or often what I'll do is I'll use my 4-map selectable because I want to put the 4 different types of images I want to see. And typically I'll look at a tangential curvature, corneal thickness, and then front and back elevation are my favorite ones to look at for most patients. In this case, we can see that our patient's HVID is 12.2. So again, that's important if we're going to use that data to design a lens. I like to run the Bell and Ambrosio enhanced ectasia display just in case. It only takes a few seconds, and we run that on every patient prior to progressing into their lens fit. In this case, our patient comes out bottom 2 images. The front difference and back difference are both green, and so we have a green light to proceed. So again, if we're using just data, we had an HVID of 12.2, and we've got Ks again of 41.9 and 43.3, and our eccentricity values there we've got at 0.56 and 0.67. And that's the data that the lab needs and wants. And that, along with their prescription, is really all that you need to give them from your map, and they will go ahead and get a lens going. So again, that's the data we're looking for on our map. But let's say we want to use a software program, and I'm just going to run through an example here of using the Wave software for this patient. And this is a video, so I'm going to start this. And so we've already put the patient's prescription in. We've chosen night lens, which is the overnight Ortho-K lens there. The template here, we're using the VST Ortho-K approval, FDA approval. Our patient's corneal diameter was 12.2, so we've selected an 11.4 overall diameter. A target power of plus 175 means our Jessen factor is relatively high. We're going to choose the lens geometry we want, and in this case, I just started with a spherical lens because I wanted you to see what that looked like. You can see by our fluorescein map, our simulation, that this is not a very good fit. Our patient did have a bit of astigmatism. And so in this case, probably going to a toric lens. This is a toric lens now. You see you can see that the fluorescein map looks a bit better aligned in the periphery. We have much nicer alignment than we did with our first one that was a spherical lens. But again, we can also go to a freeform design and get an even better looking fit. So here we've got our freeform design, and you can see as we move through each quadrant that our tear layer looks great. For me, a target is to try to keep my tear film 70 microns or below, and the top of our peaks here is sitting at about 62 to 63 microns. As we move around, again, the map, we can see we get up right up to about 70 at the deepest point. So this looks good. We should be good to go for this patient. We can kind of examine what we've got for parameters here. Let's look around, and we've got a center thickness of 0.22, which I like that because it gives the lens a little bit more stability. It makes it more sturdy, resists flexure when the eye is shut at night. So I don't like to go much thinner than 0.22. Our edge thickness of 0.17. We've got, again, an overall diameter of 11.4. And these are all parameters that we selected. This is not the software choosing that. That's us choosing that. We can choose our material here. We have a whole list of all the different available lens materials. And we've chosen, it's given us optic zone. We've chosen a 5.5 optic zone with a 6.3 intermediate curve width. So we've got a reverse curve of about 0.8 of a millimeter, which is ideal. And then really just a nice looking lens fit all around at this stage. You're going to choose your lens color, whether you want it plasma treated, fenestrated, hydropegged markings, etc. All this is good to go. We're going to hit order and our lens is going to ship. And again, if you've gone through the process, and I'm going to go back to the beginning here a little bit. If you've gone through the process here of choosing the diameter you want, and again, I think we want 11.4. If you've chosen the Jessen factor that you want, your target power again, a lot of Ortho-K lenses, their target power is a half diopter. But I like to go a little higher. I usually go about 1 diopter, maybe a little bit more for higher myopes. Again, we can change our back optic zone diameter. It defaults to 6, but if this is for myopia management, I'm going to change that to 5.5. Again, I change my intermediate curve diameter because I'd rather have more of the lens have alignment zone than reverse curve. What else can we choose? Our central clearance. This is our targeted central clearance. So about 3 microns is where we set it for. We can look for things like edge lifts, edge thickness, center thickness, etc. And so again, when you've preset all of these parameters, when you've defined these parameters, these target values, and then you let the instrument do the design and meet all of these parameter requirements that you've put in, you don't have to do anything in terms of adjusting the lens prior to the first order. But let's say you did order a lens for this patient. It came in and it fit okay, but there were things about it that you didn't like. You thought, well, we can do better than this. Maybe I want to flatten my base curve a little bit. Maybe I don't have enough power or flattening effect on my lens. Or maybe the lens is decentering a little bit because my reverse curve is too shallow, etc. You can go to the modification area right down here on the bottom left, and you see the little tools and the pencil. And you can see that when you open up that modification area box, what you're going to see is a really slick area for you to modify your alignment zone, reverse curve, base curve, and optic zone diameter, all simply just by choosing increase or decrease by the amount in what part of the lens you want to do that. Click apply and it redesigns your lens for you just like that. So modifications that follow up are real simple. Whatever changes you need to make are all made within the modification screen quite easily. So that is, again, using software to design a lens for a patient. We just click the order button and off it goes to the lab for manufacturing. So a second case, a similar situation here, just a normal patient looking for Ortho-K lens. We go ahead and do our Pentacam. If we look in the upper left corner of our screen, we're going to see that image of the eye that was scanned, and you can see a very nice and wide eye. We're getting full corneal coverage here, no lids in the way at all. Lots of good true data to work with. Moving over to the right side of the screen in the box, we can see the little 12.1. That is our horizontal white to white. That's our corneal diameter we're going to work with. And then the patient's prescription noted up there, -2, -150, axis 30. So we're going to go ahead and look at what we've got going on here. We've got, again, some toricity, a little bit oblique. We've got a white to white noted in the box at 12.1. Our corneal thickness looks good. Our anterior elevation, front elevation, our back elevation look pretty good, pretty symmetric, but we'll go ahead and run the ectasia display. And again, in this case, our front difference has got a little yellow spot, so there's a little bit of caution there. But if you actually look at the numbers, we're looking at around +5s all around in the center of the right, on the front and on the back. And so again, personally in this case, I would feel comfortable with this patient moving forward with doing Ortho-K, knowing that we can then monitor the back surface for change in the years to come. If we're doing this as a data-driven design, again, we've got our K readings there, 40.3 and 42.2, as noted in the upper left highlighted box. And if we move over to the center of our screen, again, we've got that eccentricity value at 0.7 and 0.79 in each meridian that we can then give to our lab to help them create the best possible initial lens for us. But let's say we want to do a software-based lens, and in this case, we're going to choose the Arise design. So if we've got that in our software, in the top screen, let's go back here. If you look at the menu up above in the upper left corner, it's got a tab up here that says External Software, which I'm highlighting with my mouse right there. External software. If you clicked on the external software, it's going to pull up Wave, it's going to pull up CloudLink, it's going to pull up all the different options for integrated software that you have working with your Pentacam. And so in this case, if we're going to rise design, we're going to pull up Cloud Link, and the instrument is then going to start a software that we then click to view the patient there, and it will pull up their information. And so now we've exported our Pentacam data into the software. On the upper right, we see a little box here that says edit. We need to click edit so we can edit this patient's information. Moving over to the left in our other blue box, this is where we're going to put our refraction, our HVID, and our K readings if we need to. We don't have to put K readings in. It's not required because it will get it off our map, but you can if you want to. And we do need to put that in for both right eye and left eye. Once that's put in, we're going to go ahead and start our design. In this case, we've got our prescription in, we've got the patient's information, and we are going to save that and be ready to go ahead with our lens design. So we click the lens design button, start new design on the bottom left, and the software does all the work. It's then going to give us here a picture of the design parameters. You can see in the box, it's got the patient's refraction, the Jessen factor, the overcorrection in this case is a half diopter. We could change that if we wanted to by clicking edit and adjusting that Jessen factor to 3/4 or a diopter or whatever you want. We'll give you your target, which is your refraction plus your extra RX. Patient's HVID is listed, and then your flat and steep corneal shape factors, base curves and eccentricity values, base curves and eccentricity values. The optic zone design, diameter for our lens, if we want to change that, we have the option of going 5, 5, 5, 6, or 6, 6 to whatever is ideal for the patient. The instrument has created an ideal lens diameter based on its calculations, but again, in this case, if you wanted to go a little bit larger, because the HVID is 12.1, you could easily go up to an 11.5 just by clicking. And then you've got, in this case, again, a toric haptic, which this patient have enough cylinder to make it worthwhile to be a toric haptic. It's got a summary of the patient's information, and again, the final lens parameters listed down below. And so at this point, we just click order, and the lens would be submitted for manufacturing. And again, odds are good that that would be an excellent first lens given all the data that was entered in. Just one more example of using the wave design for that same patient. We'll put their information in the spectacle plane refraction error box once we've opened up our software. And we can watch as we go through axis 30. We're going to choose a night lens. This is our overnight Ortho-K. We're going to choose the design we want. And in this case, because the patient's astigmatism falls outside of the VST approvals, we're going to choose our myopia Ortho-K template for our lens. We're then going to choose the lens diameter we wish. I chose 11.4. You can choose whatever you prefer. My Jessen factor +1. I'm going to decrease the optic zone to 5.5, and my intermediate curve diameter will leave it about 1 millimeter. Central clearance is preset then to 3. My edge lift, I'm going to choose a freeform design to begin with. I'm going to change my edge thickness to 0.17 and the center thickness to 2.2, and then I'll start my design. Again, the software will then create a lens for me that is optimized for that patient's corneal topography, but will follow the guidelines that I've entered as presets that are non-negotiable to me. And you can see again, we've got a really nice looking corneal or fluorescein pattern. Again, this patient does have, a diopter 75 of cylinder, and yet you'd never guess that by looking at their fluorescein pattern with this lens. As we toggle around, I'm going to move this little white line. It's going to move around. You're going to see our reverse curve, our tear layer depth changing, but it's always staying in the range that's acceptable. If I chose to do just a spherical lens, you can see this is not a good fit at all. This would not be an acceptable Ortho-K design. We would not get a good outcome if we had our patient in any type of lens that was spherical. If we go to just a straight toric, again, you can see our fluorescein pattern is much improved and may be acceptable for this patient. And then if we go to a free-form design, again, we're going to get the best possible alignment around that entire lens design, where that alignment curve looks ideal. We're going to choose our material, whatever you prefer, given your list of options there. We'll move ahead then, and we can place our order. And again, I typically, when we've put all the parameters in at the beginning, the amount of the center thickness, the edge thickness, the amount of clearances we want, etc., the zone diameters. Really, you shouldn't have to make any adjustments at this stage until the initial lens has been dispensed and the patient has been seen back for follow-up. So we'll just complete the rest of the information about our lens and hit order. And again, we're going to end up then most often with a really nice first fit, which will require very little modification. Our third case, just a quick walkthrough again. We've got a little higher myop here, minus 350, minus 1 axis 178 with 11.7, white to white. We can see our Ks are 41.3 and 42.4, and a nice thick cornea at 615. If we look at this patient's map, looks good, nice and thick corneas. Our Bell and Ambrosio enhanced ectasia display looks great. No signs again of any corneal disorder. And this patient was fitted in Ortho-K lenses, and I want to just highlight in this particular case some different maps, not necessarily lens design maps, more follow-up maps. You can see then in this case that our middle column shows our baseline from 2023. Our first column on the left shows then a 2-year essentially follow-up on that same patient. And we can do a differential map, and we can see the change that has been achieved through the Ortho-K. And you can see this tangential curvature map. The tangential curvature map is really ideal for looking at how well centered the lens is, how it's fitting. You can then also, I love going to the refractive map. And here we have our refractive power of our cornea. And you can see our change there is minus 3.7 diopters. If we look at the center of the difference map where it talks about refractive power, right here it says minus 3.7. If you recall, our patient was a minus 350, minus 1. So just by simply looking at your comparison map, you should be able to tell where that patient's going to be sitting with their refractive error, with their vision and whatnot. So again, you can do comparisons. You can do comparisons of any of the maps that are available. You can do a comparison again of the back surface, front surface, curvature, power, anything is available to look at. And this is just a great case. I love this. This one is a patient I fitted a few years ago already, and she came in with a relatively higher prescription, lots of astigmatism. If you look at the maps, um, she's got about 250 of cylinder in both eyes on the right map on the bottom left side, and then the left map on the upper right. Again, about 2.5 diopters in both eyes. And we fitted her with a software-based design, and you can see the outcome. I mean, that is a beautiful fit. That is a patient again with 2.5 diopters of astigmatism. You'd never guess it by looking at how beautifully that peripheral system is aligned. And so again, this complex Ortho-K fits where we take on higher levels of astigmatism or slightly different corneal shapes that would maybe have given us challenges in the past. We can use that data, we can use our software to give us better design. So whether it's using empirical designs with more data, using software-based designs with all the data we've got, this patient did very well with their fit. As you can imagine, here's their post 4 years later, their treatment map on the upper right, and you can see how beautiful that fit is with centration and how they've achieved a good visual outcome using their software-based lenses on a relatively challenging prescription and getting a good outcome. So that brings us to a close for the presentation. If you have any questions, you're free to contact me at the email address listed, and I'm happy to take more questions. But again, I just think, just to summarize, the Pentacam really, as opposed to other Placido disc topographers, the key highlights to me are the amount of true data, the non-tier layer dependence, and then all the integrated information, as well as screening our patients for those at risk before we begin the process. Pentacam has significantly helped our clinic to deliver better outcomes with a more straightforward approach to better candidates and to find those patients who are not necessarily good candidates before we begin the process. So again, thanks, Bill, for encouraging me about 5 or 6 years ago to start using my Pentacam more for my Ortho-K patients because it's definitely made a difference. So thanks for being here tonight. And if we have questions, again, I'm happy to take them at this point.
Wonderful. Thank you, Dr. Jedlicka, for sharing your expertise in the cases, and I'll be sure to pass along all of your words to to Dr. Tulu as well following the
Yes.
webinar. Now, as far as questions go tonight, we do have a question here that actually I'm going to kind of merge together, and it harkens back a little bit to the beginning of the
Hmm.
seminar, and that's when you spoke about those patients that maybe have kind of that borderline posterior surface elevation. For
Right.
those patients, do you fit those patients? And in those cases, what are maybe the factors that push your decision making in one direction or another?
Sure. So again, a couple things. One is, do we have a family history? Okay. If we talk to not necessarily always the patient, but maybe a parent if it's a child, and say, did anybody in your family that you know of have this disease keratoconus? You ever heard of that? Or, you know, and they say, oh yeah, we've got someone in the family with that. That of course is right away a serious yellow flag, if not a red flag to me. If we've got a questionable map and a family history, I'm probably steering away. Now, if there's no evidence of a family history and the shape is a bit unusual, I might look at K or I might look at pachymetry. And so if the back surface looks a little bit irregular, unusual, but the thickness is good, again, I might be more prone to go ahead and fit that patient. If we've got some shape issues, if the thickness is below normal, I might look at that patient again and say, how serious are you about Ortho-K? Would you consider a soft multifocal, for example, as an alternative? And again, in that case, it may be better if the patient's willing to go into something which does alter the corneal shape and allows us to be able to monitor that patient going forward. So I look at family history for sure as one, and then I would say that the more questionable factors they've got going on all at the same time, the more likely I'm to move away from doing an Ortho-K fit on that patient.
Wonderful. Thank you. And potentially as a segue off of that question as well, for those patients and maybe also just patients in general, what does your follow-up process look like during that adaptation period? And do you scan them on the Pentacam uh, with some frequency? What does that period look like?
Sure. So we will, the way that it usually works for us is we'll see the patient and we'll do a consultation. We'll talk about myopia management as a whole. We'll introduce the concepts of what things can be done to control. And assuming this is a child, if this is an adult who wants Ortho-K, then obviously I'm not necessarily talking about myopia management, but we're still talking about, what are your options for vision correction? Is it soft lenses? Is it Ortho-K, et cetera? And if we make a decision that we want to proceed with Ortho-K, then what we're going to do is we're going to double check the refraction at that visit. We're going to do a pentacam and we're going to do a keratograph because I want all the data I can because I want baselines of the data as much as I can because you'll never get a chance to get a good baseline again. If you do, you're going to have to wash that patient out of lenses for weeks or months, and that's no fun for anyone. So we want ideal optimal maps prior to beginning, and I want to get all of my instruments involved prior to fitting. If the patient, then again, everything checks out with their maps and we see, a healthy eye, a normal shaped cornea, they fit all the criteria for Ortho-K. Um, I'll just schedule the patient to come back in a couple weeks for a dispensing appointment, and then we'll order their lenses either empirically or with software. We don't do in-office fittings at all anymore. Um, it's far easier to tell that patient that they're going to have a pair of lenses made specifically for their eyes that are based off their prescription and their maps of their eye shape. And so again, whether I'm calling in data to my manufacturing lab or I'm doing a software-based design, we'll then go ahead and put in the order that day. And the lenses usually are there within 7 to 10 days, so that they're there waiting. And the patient comes back in 2 weeks for a dispensing. We'll get their lenses on, and again, nearly every time they're going to be dispensable. From there, we will often see the patient 1 or 2 days after initial dispensing just to make sure that they've got the lenses in and out okay, that they figured out their solutions, et cetera. And from there, I'll typically do a 1 week and a 1 month and a 3-month and a 6-month, and then their yearly exam, provided that everything's going well. And if at any point along the process we have to remake a lens to get a better outcome for our patient in terms of the fit, that doesn't necessarily mean that if the patient needs an adjustment to the base curve because it was just a little too steep or flat, but if they need an adjustment to the fit, then I'm going to kind of restart the process and get them their new lens and see them back at a week and a month, at 3 months, etc. So that's our typical protocol. It's an initial visit 1 or 2 days after dispensing, and then a 1 week, 1 month, 3 month, and 6 month, and then we go on to yearlies from there. Oh, and as far as doing a pentacam at follow-up, again, I would be more than happy to do a pentacam at every follow-up, but it's probably not necessary if you've got, and I've got a keratograph. So for personally, I like to do the keratographs at follow-ups for the first few months, and then I will probably get a pentacam again at 6 months, and then yearly we'll do both instruments again. I don't do a pentacam and a keratograph both at their initial first 3 months worth of follow-ups, just to save the patient doubling up every single time.
Wonderful. Thank you for the comprehensive answer.
Sure.
And I think for this evening, that will wrap things up for us. Just want to take one more moment and say thank you, Dr. Jedlicka, again for taking the time this evening to share your expertise with us. And then to everyone else, thank you all for attending this evening. And as a reminder, there will be a recording of this session that will be available online and sent out to all folks that have signed up. And with that, I hope everyone has a fantastic rest of their evening, both from us as well as Oculus. And again, Dr. Jedlicka, thank you very much.
Thank you for having me. Good night, everyone.
Oh, thank you.